Welcome. This is going to be the first of 3 direct shoulder lectures for Musculoskeletal 1 Orthopedics. I am Dr. Darty, and I will be performing these for you. Let's get started. Okay, let's look at a little anatomy. We are looking at a right scapula. We're looking at it from a lateral to the medial view. The right side of your screen would be the anterior aspect. The left side would be the posterior aspect. We can see that some bony margins are present here. So right next to the actual box for the number 6, just to the left of that, that yellowish bony outcropping, that would be the coracoid process. And connecting that with what is just behind it, that would be the coracoacromial ligament there, forming the roof, as it were. And then in that uh, left side superior aspect of your screen, that other bony outcropping with the wide flat plateau, that is the acromion. Alright, if we look directly under the acromion, we will see the subdeltoid bursa, represented as number 1. Uh, Number 2 is pointing to that oblong, oval-shaped structure, and that is actually the glenoid, the bony margin of the glenoid. Everything else outside of that is some degree of soft tissue, so that is the only actual bony aspect of the glenoid. You can see it's pretty shallow, it's pretty small. Alright, all these structures are flared outward because basically the humeral head would sit and fill in that space, but that has been disarticulated and drawn out of the picture. So, the humeral head surface area is about 3 times the size of the glenoid surface area, which just kind of highlights anatomically why we depend so much on dynamic muscular control of the scapula and the humerus in order to keep that humeral head in the glenoid. Some people have used the anatomy of it's like a seal uh, balancing a ball on its nose, if you've ever seen that at a zoo or SeaWorld. Um, or like balancing a golf ball on a tee, right, where the tee itself would be the glenoid and the golf ball would be the humeral head. All right, so that's the sort of relationship we're looking at. As we move on, we can see that number 5 represents the long head of the biceps tendon, which I feel like in most cadavers that I've seen blends more continuously with the labrum, which is that inner white ring going circumferentially around. Uh, we are looking straight anterior to number 4. Number 4 is going to be the middle glenohumeral ligament. This is going to be one of the things, the inert structures that check external rotation between about 45 and 90 degrees of abduction. All right, so it checks external rotation, pushes back against the humeral head, and prevents it from translating too much anteriorly. Number 3 is really a large structure. Where the tab inserts on number 3, it really goes inferiorly and much more posteriorly than you can see there. That is actually the inferior glenohumeral ligament, or sometimes referred to as the inferior glenohumeral ligament complex. There are several bands within this complex that form different roles. We really have an anterior and a posterior band mainly. So we can see that the anterior band would also limit anterior translation, which occurs with external rotation. The posterior band would limit more of the internal rotation motion because that would cause posterior translation. And number 6 also references the coracohumeral ligament. Coracohumeral ligament going from that inferior aspect of the coracoid process down to the humeral head. It's one of the limits for inferior glide. And believe it or not, it can actually limit external rotation, particularly when the arm is more down by the side, so below 60 degrees of abduction. Okay, let's talk about calcific supraspinatus tendinitis. What is this? Well, basically this is mineral deposits in that tendon, in that supraspinatus tendon, which you can see on the diagram on the right-hand side of your screen. These mineral deposits are due usually to some sort of tissue death within the tendon. So you get necrosis of that tendon. It's usually more distally, close to the humerus. Your body tries to heal itself, and instead of healing with normal tendon tissue, it really heals with a sort of reactive calcification. Now, I don't want you to think this is a bony calcification like normal bone tissue. These are some of the mineral deposits of bone, but it is a paste-like material, very much like the consistency of toothpaste, but this will infiltrate the tendon. All right, continuing on with the calcific supraspinatus tendinitis. Clinical features, well, honestly, in the clinic, it's going to present exactly like a tendinitis. I mean, you're really not going to be able to tell the difference. This could be an acute or a chronic sort of tendinitis, but when you compare the features, it should be the same. So when you look at your 18 steps, something should pop out on you as far as what should be positive and what would be a significant finding. For example, what would you see with active range of motion? Well, active range of motion with tendinitis is a lot of times you see pain when you actively fire that muscle. So maybe with active range of motion for this supraspinatus tendinitis, because it's calcific, you'll see probably pain with abduction and external rotation. Now, the reactivity depends really changes a lot of the findings, so we can kind of leave it like that for now. Pain and potential limitation with that active range of motion. What about other steps? Well, your MSTT. So your MSTT finding is probably going to be strong and painful for abduction and external rotation. Passive range of motion, classical. You could have elicit pain or symptoms, and even a potential limitation due to that pain with things that would elongate the supraspinatus, such as adduction, which you don't see done typically as much, so maybe horizontal adduction, and also internal rotation with passive range of motion. Classical, because it would elongate and stretch this tissue. Let's go back up to MSTT, and then we could look at maybe MLT. Well, MLT, you could have pain with the MLT. You're not going to necessarily have any significant finding as to the length of the muscle, because that should not be affected. That would be a concomitant impairment if it was. So you would have normal length and pain, depending on the reactivity, of course. Other definitive findings: palpation for tenderness. They should have palpable tenderness directly over the tendon. Refer to your Mattingly article and required reading from lab, which will highlight the key position in which to palpate this tendon. But when we're looking overall at our steps, what is the best step? Well, the best examination step to confirm this, all right, and it's not just a tendonitis. I know the slide says that, but what do you think would be the best way to pick up a calcific supraspinatus tendonitis? Well, if it looks just like a tendonitis, we're going to really need a definitive step that would help us differentiate a normal tendonitis from a calcific tendonitis, and that is definitely going to be imaging. Definitely going to be imaging. Now, of all those examination steps we talked about, let's talk about what we feel like would be the best ones. Well, that MSTT is going to be one of your best examination steps, and we discussed what those findings would be. Your palpation for tenderness is going to be one of the best examination steps. Your palpation for condition as well, which we haven't mentioned yet, finding some signs of inflammation, warmth, and or swelling directly over this anatomical area. And the best would be imaging. Okay, so now we're looking at a plain film radiograph AP view. You can see on that lateral aspect, you can see just outside of the margin of the humerus this pocket of white, this oblong shape of white. So basically the supraspinatus tendon, if you know your anatomy, comes and inserts on that greater tuberosity of the humerus. So where that tendon is coming close to inserting, we see this actual buildup of calcific bone deposition, basically. Not fully bone yet, just the mineral deposits thereof. And we can see that clearly here. This is why imaging would be the best step. It's clearly visible. Okay, so how do we treat this? Well, physicians treat it very differently from the way PTs would treat it. All right, so a medical physician would treat it once they catch it with oral non-steroid anti-inflammatories or NSAIDs. They can do local injections. They can aspirate this area and draw that mineral deposit out because remember we're talking about the consistency of toothpaste here. They could excise it. They'll do that under arthroscopy, and you can find videos of this on the web. Um, so sometimes this is bad enough to cause tearing, so they have to excise that area and repair the rotator cuff tear that may be present, particularly of the supraspinatus tendon. Now, as physical therapists, we don't do any of the previous mentioned things, right? So we're going to be looking at decreasing inflammation, treating the concomitant impairments that we find, sort of search and find. Decrease that swelling and irritation. Okay, if you type this in, this is just a video from YouTube of a surgeon actually basically aspirating through arthroscopy and flushing of that area. He actually makes some small incisions, pokes some holes, and you can see this fluid draining out. It's sort of graphic, but if you're a visual learner, I would recommend you type that into your browser. Let's talk about adhesive capsulitis, which is often referred to as frozen shoulder. Okay, so we could have an acute or a chronic case. Now, let's kind of talk about what this is, all right? Because generally the acute stage is missed until it moves on through the other stages of condition. You start seeing a limitation in motion, but initially it's harder to diagnose because they predominantly just present with a very, very painful shoulder. So what this actually is a self-limiting process or a self-limiting pathology in which you go through these phases of changes at the joint level, and you get other impairments as well. So there's four main stages. Okay, they used to say three, and if you look up in Salter, you will see three stages. You will see the frozen shoulder nomenclature used, so they will say it is stage one is a freezing shoulder, stage two is frozen, and stage three is a thawing shoulder. Well, there's really four stages, and that is, if you want to use that same nomenclature, a pre-freezing stage, or it's really an inflammatory stage. Right, so adhesive capsulitis means that the capsule gets inflamed and then it becomes adhesive, or scar tissue builds up within that capsule, and you get a significant limitation in motion. So when we work through these four stages, that first stage, that pre-adhesive stage or that pre-freezing stage, whatever you want to call it, they have a painful shoulder in which inflammation is building, but they do not necessarily have any limitation in motion. They just have a very painful shoulder. In the second stage, or the freezing stage, they have a very painful shoulder and they are losing their quantity of motion. They are losing range of motion because this inflammatory process has transitioned over to some scar tissue buildup as well. So they're losing motion. Then in the third stage, they are frozen, which basically means this is the greatest limitation of motion. They are the most limited at this stage, but not necessarily the most painful, okay, but they are still painful. And then the fourth stage, the thawing stage, now we're basically left with a scarred down capsule. The inflammation is predominantly gone, so they are thawing, they are gaining range of motion back, and their pain level has usually dropped significantly. Those are your four stages. And And this whole self-limiting process usually takes about 1 to 2 years. It affects females more than males, and it can affect bilateral shoulders, although you see it more often on unilaterally. And just think of this like the shoulder joint capsule, it shrink wraps down. So etiology or cause is idiopathic. Overall, the primary cause, we do not know what causes it. We do know some other things that correlate, although some weakly, but there are some things that correlate to it, such as previous trauma or a fracture in this area. What you saw previously, calcific supraspinatus tendonitis, somebody who was immobilized for a prolonged period of time, type 1 diabetes mellitus, obesity, and degenerative joint disease. These are all issues that can correlate to this, but that doesn't mean they're the primary cause. We still don't know the primary cause of this. But there can be more of mechanical causes, which are basically what I just mentioned. All right, and I already mentioned the epidemiology and the demographic. So you're thinking middle-aged females, usually Caucasian, and they're the primary population affected. Glenohumeral joint adhesive capsulitis. Now we're thinking more in that chronic stage, so we have that frozen or beginning to thaw shoulder. Now, it says adhesive capsulitis up there. I'll tell you this. This is your capsular pattern. So what really is the difference between a chronic adhesive capsulitis, in which the capsule adheres down, and a glenohumeral joint um, tight capsule, meaning the whole capsule is tight? Clinically, insignificant difference. You can't really tell. So even though it says adhesive capsulitis at the top, I think you should think of this as the exact same findings for a tight joint capsule. So this is your capsular pattern. We always look at these 5 examination findings to confirm. Alright, so we're not naming the steps necessarily, we're naming the findings. Alright, it's always these 5 things. It does not matter what joint you are talking about. The first thing is, if you're looking at active range of motion, the pattern of limitation that you see, and this is at the glenohumeral joint, you would see external rotation limited greater than abduction, which is limited greater than internal rotation. We see the same pattern in classical passive range of motion. External rotation limited greater than abduction, limited greater than internal rotation. And when I say abduction, I'm not talking about pure coronal abduction, straight off to the side. I'm talking about abduction as in true elevation of the glenohumeral joint, which basically means elevation in the scapular plane. Scapular plane, true elevation in the plane of the scapula. We have decreased classical passive range of motion. Your end feel is going to be a tight capsule. If we do accessory, you're also going to have the tight capsule end feel. That never changes. And if you're doing accessory quantity, all right, you have to really match up that classical motion to the component motions. So the component motion for external rotation is an anterior translation. So that will be the most limited, followed by inferior translation, which corresponds to any elevation, particularly true abduction. And then you have posterior glide, right, will be the least limited because that is the component motion for internal rotation. Management for this condition depends on what type of healthcare provider is seeing this patient. So a medical physician can do different things. They can prescribe, injections, which they usually use a cocktail of analgesics and anti-inflammatories. That tends to work really well in the earlier stages of condition when the patient is very painful. Okay, but us as physical therapists, of course, depending on what stage we catch them, is going to change the treatment. If we catch them early on and they're in the acute stage of condition, we want to limit the worsening. You want to decrease inflammation any way you can, modalities use. We want to teach them things such as Kahnmans functional exercise, which we'll talk about next, teach them ways to gate their pain, and teach them functional exercises, active assisted range of motion, active range of motion, particularly maintaining that really pain-free range, okay, so you don't create more inflammation so that they lose less range. When we get into more of the chronic stages, now we're really going to help with more of that, getting mechanical effects with joint mobilizations, more stretches, more concomitant impairment treatment, muscles that have gotten tight, etc., etc. This is one of the few times that when I catch them in, because I know this is a self-limiting condition, if I catch them in that acute stage of condition, I teach them some palliative procedures. I can actually do some low-level joint mobilization, like grade 1s on them, decrease their pain, teach them a couple stretches, 2 to 3 stretches, active assisted range of motion to maintain what they have and hopefully lose less. And then I basically send them on their way. I don't keep seeing this patient and just tearing up their capsule and causing more inflammation by trying to stretch them out. If I catch them early enough, I manage them by patient education and teaching them exercises to hopefully maintain and lose less of their range of motion. And then I tell them to, come back when you're less painful. All right, come back when you start to feel like you can really stretch and you have less pain, and we can start to gain that range of motion back and stretch that capsule back. I have definitely tried to manage patients the other way by seeing them through the entire course of this condition, and let's just say that I feel like I wasted a lot of the patient's money and time, and I can't say that the outcome was any better. So I poorly managed these patients early on, so please learn from my mistakes. Codman's exercise. Brilliant. This is a absolutely brilliant exercise. So Codman was a physician who developed this exercise, which he called the stooping exercise. You have a required reading on this in your notes. As a functional position, right? This is a functional exercise so that they could perform their ADLs. For example, these patients either have an inability to lift their arm overhead, or they have significant pain when they do so. So if you look at the original slide on the left, you can see that your arm overhead, you see the patient flexed up, right? They would actively be lifting their arm up. Well, if they stooped or flexed their spine down, they're pretty much in the same amount of flexion, but now they have gravity taking and distracting the joint. So things that they would have to elevate their arm for, normally, donning and doffing their shirt, brushing their teeth, combing their hair, washing their hair, showering, those sort of things. If you teach them to do those things in a stooped posture, they have way less pain and they're way more functional. So this is a way to get through the day without aggravating, irritating that tissue and causing them more pain. Um, Now, what you see it used in the clinic a lot is a distraction, pain inhibiting exercise or pain gating exercise, which is fine, all right, but you see the person there handing the weight. I really don't think that's going to help things very much, right? Because now he has to actively engage muscles to hold the weight. Another thing is if you're going to use Codmans as a palliative treatment, you need to use the body or the patient's momentum to swing the arm. You don't want them to actively swing their arm. And this is using it in a palliative manner to stimulate the mechanoreceptors or the specialized nerve endings in the joint capsule, particularly the dynamic ones. So they need a change in position or motion, so you'll see them sway their arm back and forth, forwards and backwards, that sort of thing. It can work well for that, but that is not the primary purpose. The primary purpose is it is a functional exercise position, right? A functional position for performing their ADLs. Okay, let's talk about fractures of the humerus, beginning with the radiograph on the right, which is a fracture actually of the neck of the humerus. So the patient falls on their outstretched hand, which is a Fuchs injury, and because of that upper extremity being locked and rigid and extended, the forces are really transmitted up that kinetic chain into the shoulder via the humerus. So you have this shearing force that comes through and actually shears the humeral head, um, whether it's a small fracture line or displaced fracture. But this all occurs within the capsule due to the extent of the glenohumeral joint capsule. So this is usually from a traumatic event, so the population and demographics that are most likely affected are going to be either the elderly due to a slip and fall, or more of the young and athletic population. So it's going to be most common in that elderly female population with a history of bone mineral density loss and pathological processes such as osteoporosis. Now, complications thereof are going to be, generally speaking, from conservative management. If this was a non-displaced fracture and they could reduce it externally without needing surgical intervention, you're really looking at managing stiffness and anything that would have been caused via the displacement. So we're talking about trauma to the axillary nerve. You want to inspect and manage for that. Humeral circumflex arteries, both the anterior and posterior. And generally this is going to be managed with a sling. But remember, because it's intracapsular, you're going to be thinking about effusion occurring, hemiarthrosis. So this is more easily missed due to the capsule actually adding some support to this area. Of course, not if the fracture was to the extent you see on the radiograph on your right. So continuing with humeral neck fractures, don't forget due to this location, if you look at the slide on the very right hand side, you can see in that radiograph we have a comminuted fracture. So there's multiple parts and pieces, think almost like a burst fracture. And this would all be within the joint capsule. So this could actually look like a joint pathology instead of bony structural pathology. So the physical exam, especially if this is more on the minor scale of things, is going to reveal very little evidence of a fracture because of everything being contained within the joint. So you may think joint pathology, but they tend to have local tenderness in the axilla on the proximal humerus, yet they allow you to move the arm passively because you have the capsule sort of holding things together to a certain extent. So they generally put them in some sort of sling or orthosis. You can see some pictures there of a young child who has a humeral neck fracture and how he has an upper extremity orthosis stabilizing not only the humerus, but especially in the center picture you see the strap that's going around his body to the other side's axilla, wrapping around, adding that compressive force, light compressive force to help stabilize that humeral head due to the neck being fractured. Okay, let's discuss other fractures of the humerus. So this radiograph on the right is actually a fracture of the humeral shaft or the diaphysis of that long bone. This is going to be usually a different mechanism of injury. It's not usually a shearing force, it's a transverse force like a direct blow to the shaft of the humerus. Um, So this is going to happen in things like car accidents. I know personally I had this type of fracture, and it was due to my arm being run over during a motorcycle race. So definitely a direct traumatic blow. So you get this transverse fracture. In this case, it's oblique because of the fracture line being offset. And this is extracapsular. This is located outside of the joint. So now we're thinking about more of those extracapsular problems, like that bleeding and swelling occurring outside of the joint. So we're more likely to call this edema and bleeding and such. So um, this is not going to hide itself as well at all. Oftentimes, the patient will have a flail arm, in which case their arm sort of hangs or even flails when they try to move it. They're immediately going to guard, if possible, and sort of brace and hold their arm. You get a ton of muscle guarding and sort of retraction of those muscles trying to stabilize that site and prevent you from moving it. Here, there's a lot of risk for trauma to the radial nerve. All right, and so this does usually heal, and you'll learn more about grades of peripheral nerve injuries later in the curriculum. But this does usually heal. What you're most concerned about is the sharp edges of the fragments actually lacerating the nerve. The tractional force or the compressive force is less serious than the potential laceration of radial nerve. Um, could be some sort of other brachial artery injury. But treatment, well, if it looks like it does in this slide here, you're thinking open reduction, internal fixation, ORIF. We'll see some pictures of that in the next slide. Or if it could be done as a closed reduction, meaning there's no displacement, they can usually just cast the arm. And this does heal really well. It's just prone to alignment issues afterwards. And also subsequent stiffness, particularly at the elbow due to the immobilization. All right, now we see some more pictures of this. If you look up at the top That is a picture, I believe, out of Salter, and they're trying to show you the actual guarding that's occurring and how the left arm there would be fractured and how they're actually guarding and trying to hold that arm a high guarded position. But if you look down here, you can see some humeral shaft fractures, and then postoperatively, it looks like they put more of an intermedullary rod in the humerus, which would be a much more old school approach. Now what they're much more likely to do is plating, and this could potentially be a plate because it does look somewhat square, but it's really hard to tell. You would need uh, more views than you have here. But more often than not, they actually use a plate and they use screws, a significant amount of screws and plating to get all those fragments together and to make sure they have good alignment. Okay, so here we have a drawing from Dr. Frank Netter, and this is his rendition of the anatomy, soft tissue and bony, of that upper quadrant. So I want to highlight some things. We talked about the radial nerve in the previous slide, which will be labeled number 4 on the left, and so you can see its proximity to the humerus and how it cuts over. And as you can see the bony spine of the scapula. So we are definitely looking at a posterior view, or a PA view of the shoulder, the upper quadrant. So 4 is going to be radial nerve, and 5 is going to be axillary nerve. So axillary nerve, as you can see, it's close proximity to the humeral neck, and the proximal humerus is going to be at a much higher risk for those humeral neck fractures. Whereas as the radial nerve goes distally, it comes into close proximity with the humeral shaft, and so it's going to be more likely to be affected with humeral shaft fractures. If we look at the picture on the right, we can also see the axillary artery, which is labeled number 2, and how close that is to the humeral head. And then we can see number 3 is a posterior humeral circumflex artery, so that would definitely be at risk for the humeral neck fractures. And then what's not labeled between 2 and 3 would be that anterior humeral circumflex artery. Number 4 would be the brachial artery. So if you look at it and the size of that arterial trunk going distally, especially as we get down close to the actual elbow joint, you can see how that lies right along the humeral shaft and how there is it's definitely at risk after a traumatic insult to anywhere in the shaft of the humerus. Let's move on to clavicular fractures. These are definitely going to become more common in children. In fact, they are the most common childhood fracture. Of all fractures is probably some of you out there who have fractured your clavicle. So, most common type of fracture in children. How does it occur? Well, the mechanism of injury is predominantly a traumatic event in which you fall on your outstretched hand, like a Fuchs injury, or you, and this is probably even more common, is you fall on your elbow and your shoulder is driven upward, and that is very compressive and shearing towards the clavicle. So we kind of generally put these into 3 categories. We have a displaced clavicular fracture, or an undisplaced clavicular fracture, or a green stick fracture. And the displaced and undisplaced are just named for what they are. Is it undisplaced, meaning where it should be, or has it moved location-wise due to the fracture, which would be a displaced clavicle. A green stick fracture, it's called a green stick quite literally because saplings of trees are green, and if you've ever tried to break a stick that was fresh, you may have noticed that it would bend, probably a lot more than you thought, and if it before it really broke, it didn't really snap, it would just sort of splinter and fray. And that's what a green stick fracture is. Because the bone is so young and pliable, it doesn't cause a rigid, clean fracture break. It sort of splinters and frays on the convex side. Okay, here we can see two actual and external and the internal view, or in other words, the radiograph of some displaced clavicular fractures in which the two ends of the fracture site are not connected at all. So the position of the clavicle is off. And you even when they treat this, um, if they treat it conservatively and there is no open reduction, internal fixation needed because alignment's good, there's no neurovascular compromise anywhere. You will still usually see some sort of lump or palpate a lump, at the very least the callus formation on the fracture line. What does the patient report? Well, the patient reports pain and swelling, potentially bruising in the area, and even clunking at the fracture site as those two ends of the clavicle collide with one another. Serious complications would be the neurovascular compromise. The brachial plexus is very close there, and pneumothorax, but that's going to be more common in adults. Okay, so let's discuss undisplaced versus displaced with actual slides of radiographs. So on the left, we're talking about an undisplaced fracture. If you look at the bottom side with the red arrow on the left, you'll see the actual fracture line and the two ends up against one another. And then if you look at the top slide where it says number 1, this is after they were able to reduce it, closed reduction, meaning they did not have to surgically open the patient up and insert hardware or do it manually. That way, they were able to put the arm and scapula in a position in which it was able to create good alignment, but the ends of the bone at the fracture site are still touching one another. So that's an undisplaced or a non-displaced fracture. Number 2 there on the right-hand side, you can clearly see these are examples of displaced fractures. The two ends do not line up with one another. There's been overriding of the margins, right? So the location is not similar to what it was previously to fracture, and the ends of the bones are not touching. So that is a displaced fracture. Um, Younger children tend to have much better luck with having undisplaced fractures due to the way in which their bone fractures in that green stick manner. The ends usually stay closer together. In adults, we have much more rigid bones, which are less pliable, so we get more of a snapping phenomenon, and we tend to lose alignment of those bony fragments. And in both of these, I want you to notice that the fracture line is in that middle third of the bone, so somewhere in the middle of the clavicle, and that is also the most common location for these types of fractures. Okay, here are some good examples of a picture from Salter on the left and an old school radiograph. The picture on the left is the femur, and they're trying to show you that green stick fracture in which that convex side has cracked or splintered, similar to that analogy of trying to break a branch that was fresh. All right, and on the right, we're actually looking at what appears to be the forearm there. And we can see right in the middle of the picture that it looks like the ulna, which is on your right, has a green stick fracture on the left side of the bone. So where those two bones are kind of meeting, you see that dark hollow, so on the convex side. Okay, so the two ways to manage this type of fracture medically is going to be the figure of 8 brace, which you can see pictured, or open reduction internal fixation. Figure of eight brace is usually applied after there's been radiographs and they determine there's good alignment, or they are able to achieve good alignment via closed reduction. So let's talk about the figure of eight brace for a minute. So this pulls the scapula into retraction. It unloads the clavicle, all right, because of the attachment at the AC joint and that articulation. So pull the clavicles into retraction. You create good alignment of your clavicle, and then they're held in this position with that brace, with that figure of eight brace. And you see several examples here, from using simple bandaging in the short term to using more of a rigid brace. And in children, they usually don't have to wear this very long. They just wait until there's good callus formation. So it's usually somewhere in the 3 to 6 range. Adults may have to wear it a little longer. But the rate of healing usually works out to be between 8 weeks in the younger children to about 12 weeks in adults until you have full bone healing. So during that time, they will be wearing the brace. They will not be loading their upper extremities very much. Once they get a little bit of callus formation, you start some active and active assisted range of motion, but you just have to be careful not to overload that site. So that pain is definitely your guide. Now the other case is that open reduction internal fixation, and just like in all fractures, that completely changes the management at that point. In that that is a much more stable site, and so you're usually limited in how much you are loading that area. Usually the surgeon will give this in pounds and say, I don't want you to lift anything more than 5 pounds on that side. But you're able to begin ranging actively and passively within that load limit immediately, and you do not have any sort of external bracing, or if you do, it is very much a short-term process. All right, let's discuss Sprangel's deformity. This is a congenital deformity of the shoulder complex, particularly involving the scapula. So it's a congenital deformity of the scapula, in which case you have an underdeveloped and undescended scapula, which means the scapula doesn't fully form, so it's usually smaller in size and shape, and it does not distend. In other words, it is raised up in a higher resting position, which you can see on this child's left upper extremity and shoulder complex side. So um, the patient will tend to have some muscle atrophy, or at very least poor development of surrounding scapulature and musculature. So they tend to have more of a fibrous makeup of their parascapular muscles. This, this can be unilateral or bilateral, and they tend to have a decrease in the ability to raise their arm, or an abduction type of motions. Here's a good picture showing you everything here with the child of Sprangel's deformity. So this is a more severe type, in which case you see that left scapula compared to the artist's rendition on the left side of that picture, or the A side. And you see this underdeveloped, raised, somewhat medially or internally rotated scapula, in which case it hasn't fully formed and fully developed. Therefore, a lot of the musculature in that area is fibrous, shortened, and weak and underdeveloped as well. And again, this is a congenital deformity.